Hey, Alli, have you heard the rumors about Ozempic and semaglutide and all the GLP-1 medications, good, bad, and otherwise?
There is so much, whether you're on TikTok or Instagram or talking to your friends, there is so much out there and it's hard to decipher what is what. And today we are so fortunate to have Dr. Ashwini Gore with us, who is an endocrinologist. There are not a lot of endocrinologists in the whole world, and we have one of them on the show today. So make sure you listen because she's going to give us the real scoop. Let's dive in. Welcome to the Girls Talk Healthy Aging podcast, where we dive deep into pressing health and fitness issues facing aging women. I'm Alli Kerr.
And I'm Shawna Kaminski. And together we'll bring candid conversations, expert advice, and personal stories that will inspire and empower you on your own wellness journey.
I am so excited to get to dive deeper into these GLP-1 medications with someone who prescribes these, who knows these, has all the information. We have endocrinologist Dr. Ashwini Gore with us today, and we are going to get all the deets from her. So thank you, Dr. Gore, for joining us on the Girls Talk Healthy Aging podcast.
Thank you so much, Alli and Shawna, for the opportunity. My pleasure to be here.
So let's jump in with what is an endocrinologist? Can you tell us in just laywoman's terms, what you do?
That's right. So I'll start with, most people have heard of or dealt with diabetes, thyroid. So hormones are substances that are produced by certain glands in the body. And these are then transferred via your blood to different parts of the body to have different kinds of effects. So as an endocrinologist, I deal with problems or disorders of various endocrine glands, things like insulin, diabetes, thyroid, parathyroid, pituitary glands, adrenal glands, ovaries, polycystic ovarian syndromes, low testosterone in men, and a bunch of other things.
Wow. That's so anything to deal with hormones. You are like a hormone specialist.
Yes, ma'am. There you go.
Love it. And can you tell us more about what that takes to become an endocrinologist, the journey of how you got to where you are, and a little bit more just about you and your background?
Definitely. So the short answer is it takes a long time. And generally speaking, so you're really looking at a good 12, 13 years after high school. If you're in the United States, you're looking at doing an undergrad followed by medical school, which then leads to, after you've got the basics of your medical sciences, you typically do a 3 to 4 year residency in internal medicine, family medicine, pediatrics, after which you decide you want to specialize in a certain subject. In my case, was endocrinology. Now, I will say I did not get here straight out of medical school. I did do 2 years of master's in biomedical engineering before I decided, hey, I want to go back into medicine. I also worked as a hospitalist, a hospital medicine physician who takes care of hospitalized patients for about 3 years before deciding once again, I am very interested in the field of endocrinology, which then led me to an endocrinology fellowship, which was an additional 2 years. Wow. So give or take, I think I spent about 13 years post high school to become an endocrinologist. And actually, interestingly, Labor Day weekend marks 13 years of me being here at the Jones Center in Macon as a practicing endocrinologist. And it truly is the practice of medicine. It changes with time. It's not the same for every patient. You learn something new every day. You give back something new every day.
Well, I'd say we're in pretty good hands then between your education and experience. And so we're so happy to have you on the podcast.
Thank you.
And what about how many and I don't know if you know the exact number, and if you don't, that's fine. But as far as, I'm sure this is all the things you listed, this is a big need between thyroid, between testosterone in men, between the diabetes, all these things, there's got to be a huge need for specialists like yourself. And I'm guessing there might not be enough doctors. Can you tell us about that ratio and breakdown of supply versus demand?
So yes, it's true. There's truly not enough doctors. Period. We see this not just in the United States but all parts of the world. And yet we say, as we get into specialization, we have even fewer specialists. Now, generally speaking, there's a few thousand specialists that graduate every year. I say people, when they specialize, are looking for, I guess, in their minds, fancier stuff. They want to be cardiologists. They want to be GI doctors. They want to be dermatologists. Endocrinology it's exciting to me, but it's also it's a complicated field. You don't do a lot of procedures. So there's not a lot of people going into endocrinology. I don't know exact numbers, but I can tell you this. Every year when people go into fellowships, you have fellowship programs take 4, 5, 6 new fellows for a cardiology program, for a nephrology program. An endocrinology program typically takes in 1 fellow a year, maybe 2. So the total number of graduating endocrinology fellows is extremely, extremely small. I'm not exaggerating when I say we may be 1,000 plus every year all across the United States. Now, if you compare that with just 97 million people living with prediabetes or diabetes alone, I'm not considering any other endocrine disorder. There's far too few endocrinologists in this country.
Wow. So what can we do to help get more endocrinologists in this country and around the world? Do you have an answer for that, Dr. Gore?
I don't know. All I can say is I'm a clinical endocrinologist, but I do devote a part of my time teaching medical residents and medical students. And if I can light a spark in at least 1 or 2 people, I think my job is done. Yeah. So definitely clearly some of the topics we are going to talk about today, I just think it's a booming field. It's an interesting field, and I don't see why more people would not be interested and want to deal with endocrinology, because after all, to me, that is life. These are things, these are problems, these are issues you deal with every day, day in and day out.
Yeah,
we need more people advocating for, and really empowering other patients to control their chronic issues.
Speaking of which, one of the hottest topics now is the use of GLP-1 medications. So maybe from your standpoint, you could just give us a little synopsis. What are GLP-1s? Why were they first utilized, and how are they being used now?
Definitely. So I am going to say people have heard about or started talking about GLP-1s as weight loss medication, and that's what's given them popularity over the last couple of years. But what I want people to understand is GLP-1s, or exenatide, which was the first molecule discovered, was actually approved by the FDA back in 2005. So we are really not talking new medications per se. We have medicines that have been available for about 20 some years. Now, what are GLP-1s? So GLP standing for glucagon-like peptide. Once again, just breaking it down for the common person, our bodies are pretty sophisticated, and in order to get things done, we have several messengers in different parts of the body, in different parts of the bloodstream. And I just told you, as an endocrinologist, that's part of my job, is really learning, dealing, and treating disorders with these messengers. So an interesting point to bring up. These were medical student experiments done many, many, many years ago. And what people noticed, if you feed somebody real food, if you give them food to eat and you check blood sugars, It takes some time for that blood sugar to go up. It takes 15, 20, 30 minutes for the blood sugar to go up. If you give somebody an injection of glucose, their blood sugar is going to spike really, really quickly. Now, when they were doing these experiments, if you looked at insulin response from the body, insulin is the hormone that helps you get rid of those blood sugars, mostly by using it as energy. Now, if you look at insulin response, you will be surprised to know if you inject somebody with a glucose shot and raise their blood sugar, versus if you give somebody food to eat and then look at their insulin response, the person who eats food has a quicker and a more dramatic insulin response than the one who got that IV glucose. That's what led researchers to figure out there is something in the gut. There is something in our body that's signaling the pancreas that, hey, food is coming in, you need to do something. That messenger, that something is your GLP-1 peptide. So what you need to understand is these medicines work and only work when you eat food, when you have food in the stomach. That's when these messengers work. They send a signal to your pancreas and tell the pancreas, make insulin, we need to use the sugar as energy. Now, our pancreas doesn't just make insulin. It makes a hormone called glucagon, which increases, it raises your blood sugar. So these messengers are also telling the pancreas, don't make that extra sugar. This person is feeding themselves. There's other organs in our body that are also at play. Your liver is dumping out sugar. So believe it or not, if you're fasting, you're not going to die off because you fasted. Your liver knows how to make sugar. And these messengers are now telling that liver, don't make sugar. The person is feeding themselves. So these messengers are GLP-1s. Traditionally, GLP-1 levels are pretty low in people with type 2 diabetes. And that's how the medicines came about. They came about to treat blood sugar issues or high blood sugars in people with type 2 diabetes. Over the years, as we do clinical trials and look at different endpoints, one of these secondary endpoints in a lot of trials was weight loss. And we have figured that as we regulate people's appetites, as we regulate how they use that sugar coming in, they can now lose weight alongside with it. And that's where those weight loss indications for GLP-1s came about. But simply put, GLP-1s are little messengers in your gut that signal when food is coming in, when insulin needs to be released, and when your body needs to stop making more sugar.
And one question I have, and we did a panel and we had different ladies that are actually taking the medication, and a couple of questions that they have, but one that I have, am I hearing or understanding that it's important for people to eat while they're taking the medication? Is that also, is that, and because I noticed that some people, it controls your appetite and it decreases the amount of food. And especially people that are taking these for weight loss, I know that it's really, really restricting their appetite and how much food they eat. So how does that play into what you're saying?
So I say it's extremely important for people to eat while taking these medications. Now, one, as I just mentioned, the action of this medicine is food dependent. So number one, you need some food in the gut to make them work. I guess you can go into details about hunger and satiety. And if you look at small details, then really these are not considered what I call hunger suppressants, but these are more satiety medications. So one thing I did not mention was GLP-1s slow down how food is moved through your stomach. So you get a slower blood sugar surge when you do eat those foods. What that means is now if you eat certain foods, fatty foods, greasy foods, they're going to stick around in that stomach for a very long time. They're going to make you full, but they may also make you feel nauseous or like you have indigestion or things like that. So good and bad things. These are medications that are helping you regulate the amount of food that you eat. they don't necessarily keep you from feeling hungry. Now, fullness may, for some people, feel like, hey, I'm not hungry, I don't need to eat. But others may keep eating despite feeling full just because they like food or it's a habit. So yes, it's important to distinguish those, but it's important to eat food with these medications. I look at medicines, so even if you look at the FDA indication for GLP-1s, they are to be used as an adjunct to diet and exercise. They are not miracle medicines. They are not replacements for a good, healthy lifestyle. I tell people, if this medicine is making you not eat all day long, how many days, weeks, or months can you go without eating at all? And what happens when you do start eating or introduce that food back? So you don't want to do any extreme dieting, any extreme not eating. It is extremely important that you eat food along with taking these medications. And that's the only way they will work and work safely for most people.
So if you are on a GLP-1 and you're feeling not hungry, if you pay attention to eating, say, less fat, which takes longer to digest, you might feel less nausea, might feel hunger signals a little bit more readily. So just like, what I tell my clients is, fat has 9 calories per gram. It's going to take longer to digest. It's going to keep you fuller longer. So if you're never hungry and you're on these medications, maybe reducing, there's nothing wrong with fat, carbs, or protein. But if you just, if you're eating a high fat diet, that's not going to help. That's probably going to increase, gut, like the slowdown of digestion and decrease appetite significantly.
It is. So it's definitely recommended that you have a higher protein diet. Now, we clearly are trying to get away from carbs. There again, I do not recommend a no-carb diet. Carbs are an extremely important food group. But if this helps you eat less refined carbs, if it helps you make better choices, now this could be your opportunity to add those salad or leafy greens, which will not fill your stomach up. It may actually be okay for that salad or leafy green to stay in your stomach a little longer, so you don't have diarrhea every time you eat a salad, and that's no longer your excuse for not eating healthier food. And then, again, not getting away with fats, but not eating a fat-rich or a primarily keto kind of diet may help people overcome some of the symptoms that they're having from GLP-1s.
Let's talk about some of those. Yeah, can we talk about some of the symptoms that people are experiencing and maybe why? And does it have a lot to do with how they're utilizing the medication, or is it just different for different people, or some of both?
So starting with clinical trial data, so randomized clinical studies done on GLP-1s that are available. Adverse side effects reported in the studies were, common. Well, about 16 to 20% of people, that's a pretty big number, if you will, had some kind of stomach-related side effect. Most of these were nausea, diarrhea, constipation, vomiting, and sometimes indigestion, acid reflux. Most of these side effects were mild. Almost all of them were transient, which means they did improve or get better with time. And if you look at the number of people in studies, in clinical studies, who stopped taking medication, who discontinued their medicine because of side effects, that number was about 5% of all study candidates. So 20% had side effects, about 5% could not take the medicine at all. I guess the other 15% were the ones who kind of stabilized, improved over time, or just got used to tolerating those side effects over time. But stomach-related issues were by far the most common side effect. Now, I do say weight loss was probably the most common side effect that people noticed in those trials that nobody complained about, or most people did not. Nausea and constipation or diarrhea are probably the next most common thing you'll hear of.
So when someone is given this medication, are they given instructions in terms of, ways to avoid nausea and like these negative or adverse side effects, so that they would get some counseling on maybe eating less processed or fatty foods, for example?
So this is where I say that doctor-patient relationship is so important. And this is what really scares me about the people taking these medications today. So you would hope and pray that most of them are getting prescription medication from a medically licensed professional who is then giving them instructions, both about benefits and side effects, and how to mitigate some of those side effects. So yes, you may think, oh, you do this every day, this should be an easy visit. No, there is no easy visit. You start somebody on a GLP-1, you have to spend 15, 20, 30 minutes or more talking to them about what to expect with the medications, how to change their lifestyle to make the medicine work, to get the most benefits, but also to mitigate some of the side effects. My concern is I see a lot of people come into me saying they got a Groupon, they got online, they went to a weight loss clinic, did not see even a real person, filled out a questionnaire, and had a medicine prescribed and shipped to them. Oftentimes, not the actual medicine, some bottles or vials, or some clear syringes with something filled in, not labeled. I have had a person get me a Ziploc bag full of syringes with absolutely no label on it, saying, it's working and it's making me lose weight, so it must be that semaglutide that they sold me. So yes, there has to be a very clear discussion about benefits and risks. I generally like, now again, being an endocrinologist, we do say, I think I'm spoiled to have that registered dietitian on board with me. And I want every person who delves into weight loss, whether to mitigate any of their medical conditions like diabetes, high blood pressure, high cholesterol, or simply to lose weight in order to gain better mobility, less joint issues, no sleep apnea, whatever the cause is. I think doing it alongside with medical nutrition therapy, understanding the benefits and risks is extremely important.
Yeah, that's one of the things I'm hearing commercials now, Dr. Gore, about these places where you can get these GLP-1 medications that are, not just online, easy. They have Dave and quote the pricing. So that is becoming, there definitely are pop-up shops all over in America, at least. Shawna's in Canada. And so I don't know if she's seeing the same thing, but I'm definitely seeing that here. And it's, there's no guidance. Or one of the ladies that I talked to for our panel that did not end up being on the panel, she definitely had some rough side effects. But I think that her providers, I don't know that she went to the actual provider, that she went and saw a reputable or someone who, like yourself. And one of the things we mentioned early on is that there's not a lot of yourselves. There's not a lot of endocrinologists. So I think that also opens the door for so many of these kind of side shop popping up around. And so who would you, where would people start if they have questions, if they're whether they're looking at this for weight loss or diabetes? What would you recommend someone who's maybe listening that has not seen a provider yet, but is curious, or maybe looking at online or talking to friends? Because that's how a lot of people find out about these medications. Where should they start?
So always a medically licensed professional. Yes, there may not be enough endocrinologists. And I really don't think we have enough primary care physicians or family physicians either. We do have a lot of physician extenders now too. So I'm not negating the role of nurse practitioners, physician assistants that they play in here too. What I really want to tell people is one thing. And this is just me, not even as a physician. If I'm going to take a medicine, if I'm going to take something, I want to look at benefits and risks, and I would like to discuss it with a live person who I trust, whose knowledge I trust. I look at, everybody is a doctor now that we have Dr. Google out there. But you really cannot replace clinical trial data, PubMed data, with what I call a quick 10-minute Google search. So please, this is your help. This is, you're looking years and years of your life, not, oh, I want to lose 10 pounds in whatever, 10 weeks. So do your research, at least speak to your primary physician, speak with your family physician. Get an opinion. That's number one. The other thing to consider, anything that you do, anything literally in life has effects, it has side effects. So I tell people, you could drink too much water and have seizures, could have low sodium, you could die. So there's nothing in this world that is 100% safe. So don't let anybody tell you that. Don't even let your doctor tell you this medicine is 100% safe, take it, nothing will happen. Everything, as I said, has benefits and side effects. And a medicine may be excellent for many reasons and for multiple people, but not every medicine is made for every person. So you have to look at your characteristics, your ethnicity, the genetics that you inherited, the clinical features or your lifestyle issues that you have, medications and medical problems that you deal with, and then figure out if a medicine like this is going to be a good choice or not. Your primary care doctors could make those decisions for most people at hand and give you good advice, or at least get you started till you get to see a specialist. And then kind of take it from there.
Yeah, that's good advice, because Dr. Google is helpful in maybe putting you in the right direction. It's not the end. It might lead you in a direction, and then you need to speak with someone. Now, right. We're hearing all kinds of things that GLP-1s are miracle drugs and go. But what are things that would cause us to pause? There, like you said, there's costs, or there's benefits and costs. What's the downside? We need to hear a really balanced perspective of this.
That's right. So number one, FDA indications. Now, I say common sense. If you are allergic to a medicine, you take a medicine and you have swelling of your face or your tongue, you have shortness of breath, you break out into hives, stop the medicine and don't take it. Now, if you look at contraindications mentioned on the prescribing information for this medication, then there are certain people with medullary thyroid cancers or family history of medullary thyroid cancers that should not take GLP-1 medications. This is where an expert does come into play. Most thyroid cancers that are diagnosed and treated are papillary or follicular thyroid cancers and are okay. It is only specifically the medullary thyroid cancers or certain multiple endocrine neoplasia syndromes, we call them MEN syndromes. Those are the only patients who absolutely should not take GLP-1 medications. Now, GLP-1 medications do work through your pancreas. There are some concerns about pancreatitis with the medications. And people who have a history of pancreatitis, once again, should not take these medications. Now, outside of those, there are no absolute contraindications. This is where we start talking about, hey, let's look at benefits and risks. And here's where I tell people, I have had people come up to me and say, I started this medication, I'm feeling a little bit nauseous, but I think that nausea is improving every week that I take the medication. It's giving me the effects that I want to stay on it. Yes, that's an informed decision, and we decide to monitor and we keep on it. I have had a patient come to me and tell me this medicine is a miracle. It's made me lose 20 pounds. And then she tells me she is so sick, she is throwing up and sitting by the bathroom at least 4 days of the week, every week since the day she started the medication. To me, that's a red flag. That's an absolute no. I don't care how much weight you lost on that medication. That's not normal, and you should not be on the medication. Constipation. People don't think too much about those bowel movements. I think as people are getting into dieting, keto diets, high fat diets, there is that general tendency to accept constipation as a side effect of your lifestyle change. It is absolutely not okay not to have a bowel movement for 7 to 10 days. You will see people who are severely impacted going to the emergency room to get disimpacted. I have had people rupture their bowels because of these medications. So anything that's way out of the norm is not okay just because you're losing weight on this medication.
It's so interesting how some people are quite desperate to lose weight that they will accept many other things like not having a bowel movement for 7 to 10 days or having to go to the emergency room, but still happy that they're taking the medication because they're losing weight, but they're, impacting health negatively in other respects. Mm-hmm. No judgment. I mean, I understand the desperation of people.
That's right.
Yeah.
Mm-hmm.
Yeah.
And what would you say, Dr.
So
Gore?
This is what I tell my patient. Mm-hmm. Yeah. No, you want to complete your question, Alli?
You go ahead. We want to hear you.
Yes. Okay. So I was going to say, so truly, no judgment. But this is what I like people to know. So just think about smoking cessation. Some people can just quit cold turkey. Other people need help to do so. I think it's the same with obesity. It's a chronic medical condition. You can't look at it. You can't look at somebody and say, oh, you just eat too much or move too less, and that's why you're gaining weight. It is a chronic medical condition. There's different reasons why people may be putting on and holding on to that weight. And some people may be able to follow a strict lifestyle change and get rid of that excess body weight. And for others, it is very crucial, it's very important to use that medication therapy. I say the same thing. I mean, being overweight is hard, exercising is hard, but to me, side effects from a medication like GLP-1 is also hard. And I guess each one of us kind of chooses their hard. So you ask me, yes, I'm a marathoner, I'm a hiker. I would much rather slog 26 miles to earn those 2 slices of pizza that I don't feel like eating after those 5 hours. But I would never want to inject myself make myself nauseous. And yet I will have people tell me, it's okay, I'll deal with nausea all day. I hate sweating. I don't like to sweat. So truly, every person is different. No judgments here. What I really want to bring up, though, is obesity it's a chronic medical condition. And this is where I also put in this. There's no miracle medicines. You have to find a balance between your lifestyle and your medication. And this is something that you're probably going to deal with all your life. It's not going to be a 2-week or a 6-week thing that you get rid of that extra body weight and it's gone. It's not going to be the jump start that I need and then every life will be good again. You really have to look at it. And that's why when you're considering treatment for something that's probably going to be lifelong, you really have to weigh your benefits and risks.
Is this a medication that I have one client that is disappointed to think that this is a medication she'll have to be on for the rest of her life? Is there a weaning off? Is what is in the future for people that are on the medication? Is it a lifelong sentence that they have to continue it the rest of their life?
So the honest answer, as of right now, from the limited data that we have, so going back to GLP-1s may have been around for 20 years, but we have only been looking at them as diabetes medication that needs to be started and continued for the rest of your life.
Okay.
We have really not looked at weight loss other than maybe the last 4 years or so. So the data we have is limited. It's from about the last 4 years. Now, one of the medications out there, Mounjaro or tirzepatide, had a study which went out about 40 months, so short of 4 years, and people lost weight and continued to lose weight while taking the medication. When patients stopped taking the medication, then a lot of that weight loss stopped. Some of the weight came back, and almost everybody had gained at least some weight. I'm not going to say they gained back all of their weight, but most people had gained back at least some of their weight by the end of 1 year of being off of the medication. So, yes, the honest answer is unless you've made big lifestyle changes that are in place that are going to keep you going, these are not medicines that you can look at as, hey, let me take this for 3, 6, 9 months or 12 months and stop. You have to look at it as a chronic medical condition. You have to look at taking these medicines for the rest of your life.
I understand that those clients or patients that are taking the medication that do change their lifestyle, just like those that are losing weight without the medication but are able to change their lifestyle, their ability to sustain the weight loss is likely improved. The people we had on the panel spoke quite at length about the reduction in food noise that helped them, resist, like they just stopped thinking about food all day long. And so that helped them quite a bit. Can you speak to, the idea of food noise and how GLP-1s, like maybe the mechanics of how GLP-1s help reduce food noise?
So as I mentioned, they're really not hunger hormones, but they're satiety hormones. So because you feel full, you don't want to eat. And it's not just want to eat. I will go ahead and say, people tell me, my patients tell me, oh, it's not just food. I drink less sodas. I drink less alcohol. So there's definitely a clear link between, yes, they think they don't feel hungry enough, or at least that food is not tasting so great, or it's making them nauseous, and for whatever reason, they can get away with not eating. What I'm trying to say, though, is you've reduced that food noise, but the data we have on this is still very, very young. You can do it. You can do it 1 year, 2 year, 4 years at the most. We don't know what happens 20 years down the road. We do know that the minute you start tapering some of these people off, I have patients, for whatever reason, whether the medicine was not available at the pharmacy, whether it was too expensive and they could no longer afford to buy the medication. So for whatever reason, if they decided to cut back, or even just, hey, I decided to stretch my medicine and now I'm taking it every 2 weeks instead of 1, a lot of these people will tell you, I start feeling hungry that second week. So those effects are not long lasting. They haven't changed something in their bodies. Those are messengers that are only working as long as you take that medication. So that's the concern. Now, I will go a step deeper. I know we did not delve into this yet, but we talk about
Dr. Gore, can you go back, because your audio was cutting out, and I wanted you to say that again about they only work as long as.
So all of these medicines are only work. So your effects are based on you taking medication. So most people, once they start stretching out that medicine, they go out 1 or 2 weeks, they start to notice that food noise, those hunger pangs, they come back pretty quickly for a lot of these people. So you're not chemically inducing a permanent change in your body. That chemical change is limited to those times that you're taking medication for it. And that's what makes us feel, at least right now, with the limited knowledge that we have, that these are medicines that you would need to keep on taking for them to work the way they're working. Now, this is where I will go a step further and say, going back, I know I keep harping about a lifestyle change, but weight is just an easy number to measure on a scale. But your weight doesn't tell you, is this body fat that you lost and you lost weight? Did you lose muscle mass and did you lose bone density? So what we do know, again, from limited weight loss related studies on GLP-1s, you don't just lose body fat. You lose muscle mass and you lose bone densities. So now think about, you are using a medicine to lose weight, to reduce food noise, but you haven't exercised, you haven't done strength training. If you lose muscle mass, you're losing part of your calorie burning equipment in the body. You are getting weaker. And if you lose bone mass, you're increasing the tendency to break bones, especially for women and women after menopause. So consider all of those in the long run. And you have to think about all of those. So there is no miracle medicine. This may help you and now allow you to exercise or strength train. This may help you get rid of some of that food noise and to make food choices which you can then sustain over the long run. But as it's having its good effects, it is having some bad effects on that body too that have to be combated by diet and exercise.
So if someone is dieting without exercise and without GLP-1s, will they lose a similar amount of muscle and bone density, or is it accelerated with the use of GLP-1s? My understanding is that the muscle and bone density loss can be offset in both patients by regular, consistent resistance training.
Now, I certainly say, so the honest answer there is, I guess you have to compare apples to apples. Now, for most people, when they are making a lifestyle change and losing weight, and don't get me wrong, there are many successful people who will lose weight with a lifestyle change, but oftentimes it's a slow, gradual weight loss. Yes, weight loss of any kind will come along with muscle loss and bone loss. The concern with some of the GLP-1s is that weight loss is coming extremely quickly.
Yeah.
And that's where the concern for losing that muscle mass or bone mass extremely quickly also comes in. No, we don't have any data or no randomized clinical trial to say, these are the people in the intensive lifestyle modification group, and these are the people in your GLP-1 group, and this is exactly how much fat, muscle, or bone mass that they lost.
Yeah, it's just a caution that anybody using the medication should very much consider resistance training, because they may be at risk for accelerated muscle and bone density loss because of the accelerated pace of the weight loss. That makes perfect sense.
You see a difference with patients that are taking this for diabetes versus patients that are taking this for weight loss, as far as just the effectiveness, as far as their side effects, as far as the food noise effects? Any differences between those two groups that you're seeing?
So there's inherent differences between the two groups. Now, people with type 2 diabetes generally have what we call insulin resistance. And I definitely say diabetes is more complicated than just insulin resistance. But insulin resistance is something I think we should talk about or understand. Now, insulin is that key hormone. It's the transporter hormone. So when you eat, it's responsible for clearing out the sugar out of your bloodstream and giving it to different organs and tissues where it can be used as energy. And what starts that whole process of insulin resistance is initially the insulin is not working efficiently, or those muscles and tissues are not effective enough in picking up that sugar or energy, and the body is making more and more and more insulin. So, with that said, or not delving into that too much deeper, people with type 2 diabetes in general tend to be more insulin resistant and have a very hard time losing weight.
Mhm.
So, when you look at weight loss medications, you are going to see good weight loss results all across the spectrum, but people without diabetes lost a lot more weight than people with diabetes. And it just brings it back to the pathophysiology of type 2 diabetes. Now, the second thing to consider is most people with type 2 diabetes are on a lot of other medications, or there is no one medicine fits all and clears all the defects in the body. So they are often on multiple medications, sometimes on multiple doses of insulin, other medications that can make them secrete insulin. So these people are much more likely to have low blood sugars and related complications. Low blood sugars from taking these medicines for weight loss in people without diabetes is actually extremely rare. Some studies had 0%, absolutely no hypoglycemia. Other studies had a very small 1 or 2 or 3% hypoglycemia. So your type 2 diabetic patients are inherently different. Their hormones, their pathophysiology is different. They have a harder time losing weight. They may have more side effects, not necessarily related to the GLP-1s themselves, but related to the combination of medications that they take. There again, or especially so in these people, it's extremely important that they do any kind of GLP-1 therapy under the supervision of medical personnel.
Yeah. Yeah.
Are there some people that these medications don't work for as far as weight loss, that they take the medications and they're not seeing weight loss? And who are those? Who are those people typically?
So yes, that's true. And we don't know the answer yet. So all I can say is, so this may be my reason to encourage more people to go into endocrinology. Yes, endocrinology and medical genetics. Let me broaden that spectrum for you. There's so much that we have learned about our bodies, but there's so much stuff that we do not understand. All I can tell you out of my clinical experience and literally prescribing GLP-1s now for 13, 15, actually 20 years, I've been prescribing Byetta since 2005. Only about 80% of people respond to GLP-1s. There's a good 20% that do not see any weight loss with the medication. I wish it was as simple as, hey, they're not following their diet or they're not exercising. Yes, that's a big part of the reason some people fail and some people succeed. But it just brings up to there's multiple other hormones and genes in the body that regulate weight that we don't know about. We are still in the process of learning. And I will open that to say there's actually already multiple newer drugs in the pipeline, which act on more messengers than just GLP-1 or GLP and GIP-1. So we may be knowing a lot more in the upcoming years.
And I love that you said that we don't know yet. And I think that as consumers, that's really hard for us to hear sometimes. And I think that that's also maybe why sometimes we go to the person online that's selling us the magic pill, or because they have the answer, and we don't have all the answers. And like you said, we don't have a lot of people we don't have enough people in these fields. And that is going to take more people studying these things, more time studying these things. And so it can be frustrating for us as consumers to be told sometimes we don't know all the answers. So thank you for even that. That is that's something that we need to learn how to hear. As I will speak for myself as a consumer, we need to learn. I need to learn to hear that. What about with GLP-1s? Do you see, you mentioned some things that you see kind of coming down the pipeline. Will these be oral pills eventually? What do you see in the future for these medications?
So right now, I'll start with what we have approved. Uh, so we have liraglutide, which is sold under the brand name Victoza for diabetes, was approved under the brand name Saxenda as a daily injection for weight loss. Then we have semaglutide, which really took the world by storm, Ozempic for diabetes, and Wegovy as the brand name for weight management. And then a few years later came in tirzepatide. Now that's Mounjaro for diabetes or Zepbound for weight loss. And Mounjaro works on two messengers, GLP-1 and GIP, and it showed better effects on blood sugars, on weight, than the GLP alone, which is semaglutide. So yes, now we have drugs which work on three messengers instead of two. We do have pills that are coming out. There is a pill in the diabetes spectrum. Semaglutide is already available as a pill to take every single day. But we may soon see that come in as a weight loss medication. And then finally, as I said, they're trying to combine therapies. So if you look at now, we know we've achieved weight loss. Now we want to see if we can combine another medicine to get the same or more weight loss, but maybe less side effects. So combination therapies are something that are being studied. The study I'm most, I would say, excited about is they are finally looking into muscle loss, because to me, that's going to be the big one. If these medicines are here to stay, then we don't need a whole population of people who cannot walk in their 60s. So they are looking at medicines which will actually preserve muscle mass as people lose weight. So yes, lots of exciting stuff in the endocrinology/weight loss pipeline.
Yeah, and that's interesting. That's fascinating how if someone's eating less, how they're going to preserve muscle. So that'll be really interesting as to how those medications work. What about age? Are there, like, because of the muscle loss right now, is there a certain age that you are really hesitant to prescribe these medications because of the concerns of muscle loss, especially in women or men
and children?
So prescribing information-wise, no, there are really no age restrictions. Now, I definitely say my practice is adult endocrinology. So typically, my patients are 18 years of age and older. I would like to say I have 75 and 80-year-olds on GLP-1s, but typically for treatment of diabetes and diabetes alone, not for weight loss management per se. Any medication has to be administered carefully in the older population. So typically, I see myself using the smallest dose possible that can be used to achieve the effect that we need. So yes, frequent monitoring, looking for side effects, and looking at just a whole medicine reconciliation, not just your GLP-1, but everything else that they are taking that GLP-1 would impact. Actually, since we are talking about GLP-1s impacting medication, I will go back to a younger population. We have a lot of women who take birth control pills, and these medications do affect how food moves through your stomach and is digested through your stomach, which means it may affect how you digest and absorb your birth control pill. So, hey, if anything, I'll say check out Dr. Google for Ozempic babies. Now, seriously, but in all seriousness, yes, it may affect how your oral contraceptive pill is absorbed. So if you do not want to conceive, do not want a pregnancy, people should be taking extra precaution while on these medications. Women of the childbearing age should also be very careful because we do not know the effect of these medicines on the growing fetus.
Interesting. One last question before we wrap up, and that is we're hearing about the food noise and the use of GLP-1 or GLP-1-like medications for the use of addiction therapy, other than food addiction.
So yes, it's true. There are more and more studies coming out showing, just as I mentioned, people have come and told me they drink less. I've occasionally had a patient tell me they gamble less, or things like that. But really, so the best we know right now is GLP-1s do cross what we call the blood-brain barrier. So again, just in simple language, our brain is a very important organ in the body, and there's a special barrier that protects it, which means not all medicines, not all substances that we ingest are allowed to get into the brain. But GLP-1s are one such substance that do have receptors in the brain, and they cross and go in. We think because of their effect, their central effect to tell your body, hey, I'm not hungry anymore, I'm full. You could say they reduce hunger literally and figuratively, if you will. It doesn't have to be hunger for food always. It could be other addictions. There again, we will need a lot more randomized controlled trials to look at these medications. I'm not going into detail, but there are other weight loss pills available that also have kind of looked at that lower addiction probability. So it's definitely some more probably good news to look at and to study in the future.
And I know that's the last, but I want to ask about trials because I know that we need data and we need research. So do you have any suggestions for people that maybe would be willing to participate in trials, especially if they're taking these medications? Is there somewhere that they could go to find out about clinical trials?
So actually, I'm glad you mentioned it. So we do, our office, the Jones Center here in Macon, partners with the East Coast Institute of Clinical Research. Now, this is a clinical research institute out of Jacksonville, Florida, and they do have presence in doctors' offices, I say pretty much all along the East Coast. You do not have to be a patient of the Jones Center to call and be enrolled in a clinical trial. We will advertise clinical trials as they come along, or patients will call the office and join a trial. I just say clinical trials, remember, have very strict criteria, and they are typically looking for a certain age group, a certain subgroup of people. They want certain A1Cs or weights. But yes, there are, if you look up ongoing clinical trials, then as I mentioned, I can tell you about our office here in Macon, but I'm sure you will find other ongoing clinical trial data. But clinicaltrials.gov would be the best place or your most authentic resource to go to.
That's really helpful. Ashwini, if you had a wish for our listeners today, what would it be?
So I think I'd like to just kind of wrap this up and say, I don't want anybody to really associate a taboo with overweight or obesity. It's just like diabetes, hypertension, high cholesterol. It's another chronic medical condition that people deal with, some in better ways than others. There is no shame in needing help with medication to control that condition. There is, finally, for the first time in decades, some good medication out there that could be beneficial. But what I really pray you find yourself a good medical provider who can sit down, look through all of your medical conditions, your genetics, everything, and then come up with a good plan based on benefits and side effects. always do this in addition to a lifestyle change. So if you can institute a lifestyle change along with your GLP-1 medication, you're going to get more out of your medication. You're definitely going to get more bang for your buck. You're going to retain those good muscles, those good bones that have helped you so long. And then finally, at least for the time being, I say don't look at it as a magic wand that's going to cure all. But with patience and by sticking with that regimen, like you would with any other medicine, I think it could lead you to a lifetime of fitness and good health. And that's truly, at the end of the day, that's what I wish for all my patients, all my clients. Actually, I'll just make a note here. I've been a pink lady too with Alli. And as I say, so yes to all the pink ladies out there too. My hope is really for ultimate good health. At the end of the day, I do believe in hopefully that lifestyle change or that miracle medicine plus lifestyle change that may ultimately let us live disease-free and medicine-free in the long run.
What's your wish, Alli?
Well, we love our pink ladies at the Pink Physique, and we thanks for that little plug there, Dr. Gore. My wish is that we get that people do find a good provider, and that I think that's my big takeaway. So find that good provider. I'm going to second that.
Yeah, and my wish is just like yours, Dr. Gore, in that make an informed decision with your medical provider, weigh the costs and benefits, before, jumping into something, but don't also, just don't be afraid of medical technology is wonderful, but just to understand the costs and benefits. And the best way to do that is with a good discussion and informed consent with your medical practitioner.
Thanks for listening. You'll find me, Alli, on Instagram at Alli Kerr Fitness.
And you'll find me, Shawna, on Instagram at Shawna Kaminski. Feel free to pop us a DM with questions and or feedback. If you're enjoying the Girls Talk Healthy Aging podcast, please subscribe and share it with other health-minded women. Ratings and reviews are also much appreciated and help us get our message out to a larger audience.
Until next time, be healthy and be happy.